I'm going to change gears a little bit now and obviously talk about something that when I was in school we had maybe 3 or 4 options for this, and none of them were absolutely the best possible mechanism of reducing patients' potassium level. But new and emerging potassium binders in the long-term management of hyperkalemia, expanding the role of the pharmacist in patient identification and risk reduction. And with us today is, again, one of the preeminent experts in renal disease, Dr. Darren Grabe. He is the Associate Professor of Pharmacy Practice, Chair, Department of Pharmacy Practice at the School of Pharmacy and Pharmaceutical Sciences in Albany, New York, at the Albany College of Pharmacy and Health Sciences. Dr. Grabe received his doctorate in pharmacy from the Albany College of Pharmacy, then went on to do a nephrology internal medicine residency with nephrology fellowship, also at the Albany College of Pharmacy. He is significantly well known in this arena. Most of you are well aware of his chapters and contributions to the literature. With that, I'd like to introduce Dr. Grabe.
Appreciate it. All right. Well, good afternoon, everyone, and thank you for staying with us this late in the day. I'll see a few of you get some nodding heads after dessert. That's always going to be fun. I always find it funny that they do dessert, and then after this, they're going to talk about insulin and metformin. It's a perfect match. I spent a lot of time in Albany, and I'm still in Albany. I did take a break. Was in Texas for 2 years, at Texas Tech University, and after being there for 2 years, my wife realized that she didn't like it in Texas and wanted to come home closer to home, and we are now back in Albany. So today we're going to talk about hyperkalemia and agents on hyperkalemia. This is something that's kind of exciting for me because this is my bread and butter. I work in a kidney disease clinic in Albany, Albany Medical College, and this is something we regularly deal with in terms of how to manage hyperkalemia. Today, I am going to talk about the one new approved agent, but I'm going to talk about one agent that's not yet approved, and I'm going to talk about some indications that may not necessarily be in the package insert. The objective is first talk about hyperkalemia. That's probably something that you never did before, is talk about the epidemiological evidence and the burden to the healthcare system regarding hyperkalemia. We're going to talk about factors that contribute to hyperkalemia. We're going to go back in school and talk about pathophysiology of hyperkalemia. We're going to take a look inside the kidney. How much fun is that, right? So exciting. That's the response I get from my students. Okay. And we're going to talk about the new binders and then how to integrate those new binders into practice. Okay. So hyperkalemia is a result of several different overall arching sort of diagnoses. And what you have here in the center circle, this kind of weird Venn diagram, essentially is either redistribution, decreased secretion, or increased intake. And it may be a combination of those factors. Now, surrounding the condition of hyperkalemia are 4 major conditions: diabetes, CKD, acute kidney injury, and chronic kidney disease. And within those are conditions or drugs that may contribute to hyperkalemia within those certain subsets. And as you might imagine, as you know, those things are not mutually exclusive. So the only thing I don't like about this graph is that it presumes that somebody might only have diabetes or might only have CKD, when in fact we see patients with all of these things all together. Cardiovascular disease, they may have underlying chronic kidney disease, they have diabetes, which is causing acute kidney kidney disease, and then an acute kidney injury is insult occurs. So somebody can have all 4 of these. And my patient population that I deal with has any number of these at any given time. Now, this is a couple of pieces of data. The first set of bullets comes from the government data regarding the number of admissions for hyperkalemia. And this is the most recent data from 2014 that's published. There was about 76,000 patients that had admits to the emergency department, half of which were actually admitted from that for hyperkalemia. The average length of stay was 3.3 days, and the cost to the system or to the patient was about $30,000. The next set of bullets is some data specific for patients with kidney disease. And the range, you can see, ranges anywhere from 7 to 80%. And the range is wide because you have different stages of CKD, different levels of the kidney to get rid of that excess load of potassium. So the incidence really depends. And in the same publication comes this table, which is reformulated to things I think make sense. And in essence, as the kidney function falls, as measured by eGFR, the amount of time spent at an elevated potassium level increases. And you can see the different stages that they have, the above 5, above 5.5, and above 5 or above 6. And one might argue, obviously, the higher the potassium, the greater the risk. And certainly that's true. As we all know, potassium is part of the lethal injection for patients on death row. So it's a serious issue. But what I'm going to tell you is that I believe that even a potassium 5.1, 5.2 is important to pay attention to. And that's what I'm going to try to convince you of today. In this other publication, what they looked at was essentially what they termed ambulatory care sensitive conditions. What that meant to them was conditions that were essentially conditions they could have dealt with on the outpatient basis, but instead those patients were sent to the hospital. And what they looked at was patients with CKD, GFRs between 15 and 60. And when they looked at the entire data, they found about 25% of those hospitalizations were linked to one of those 4 conditions. And the majority of those hospitalizations within that were encounters related to heart failure or hyperkalemia. And I'm going to tell you those are actually linked in many ways. So again, hyperkalemia becomes a problem and something that we're perhaps not recognizing, and we actually have struggled quite a bit in managing from a chronic point of view. Now, some of you might be in a health system, in a hospital, and you're familiar with the acute management of hyperkalemia, and that certainly hasn't changed too much, but I guarantee you probably will in the next year or two. But we protect the heart with calcium, we give it insulin, we give a number of things, but from a chronic management, we have poor options. Here is a U-shaped graph looking at potassium levels and the associated mortality risk. And as you can see, as potassium goes down or potassium goes up, mortality increases. And what's significant about this graph, which I will point out here, is that even though this doesn't look very impressive here, this level of potassium between 5 and 5.4 is statistically significant in this study, meaning that there was a significant increased risk of death even with a small increase in potassium, a 14% increased risk of death. I think that's significant, and I think we need to pay closer attention to that. Same study, similar graph. This is cardiovascular events. Again, low potassiums and high potassiums mean poor outcomes. So we clearly are very focused on making sure potassium levels sit within the therapeutic range. Now, the conditions I mentioned before are often treated with drugs that cause hyperkalemia. In fact, if you look at hypertension and heart failure and diabetic nephropathy, the top drugs used in each of those conditions cause hyperkalemia. And when you look at the strategies, just for example, for hypertension, you have a couple of different ways to go about this. The first strategy is perhaps you pick one agent for hypertension, you maximize that dose, and then you add a second drug. The problem with that strategy is the fact that it doesn't necessarily, you may actually see more adverse effects with that first drug you chose. So we go to strategy 2 perhaps, and that would be, well, we start one agent and then add a second agent before the maximal dose. Reasonable strategy. Now we're adding 2 drugs, both of which may have adverse effects. All right? And then the third strategy is start 2 agents at the same time and titrate the dose. The final strategy is we all talk about the DASH diet, right? You've heard about the DASH diet, the dietary approach to stop hypertension. Mother and apple pie, all sorts of good stuff. What's the problem with the DASH diet? Related to hyperkalemia, it's filled with fruits and vegetables. So we actually, in our clinic, don't do a lot of DASH diet recommendations because it worsens hyperkalemia for us. So again, you have to be careful with those recommendations in those specific patient populations. Let's look at evidence-based medicine. That's what we all preach, right? We want the evidence. We want to prove, we want to do things right for our patients. Well, here's the RAIL study. Anyone remember this one? This is a patient with severe heart failure. It was published in 1999. And in this study, what they showed in patients with severe heart failure, if you added spironolactone, you reduced death by 31%. In fact, they stopped the study early because it was such a substantial effect that they didn't want to withhold that treatment, that spironolactone, aldosterone antagonist, to patients with heart failure. Right? Great recommendation. We should be doing it. And as a result, spironolactone rates of prescriptions went up significantly after the RAILS trial. But so did hyperkalemia. Now we can't use the drug that's proven to reduce mortality in a patient that deserves it. Let's talk about the other agents as well. Here's potassium is greater than 5, potassium is greater than 5.5 on each of these panels here. Again, I made the argument that greater than 5 is significant. And you can see that each of them has a certain risk, with ACE inhibitors associated with the greatest risk of hyperkalemia, regardless of level. And obviously, diuretics having the lowest risk, so reduced risk. And so why would that be? Why would ACE inhibitors be more pronounced hyperkalemia than ARBs? Anyone come across this? Ever thought about that? Does it keep you up at night? Probably not. It does for me, because I used to read these and I was just like, I can't figure it out. And then I thought, and this is a hypothesis, you can argue with me, I'd be happy to entertain any other hypotheses, but my hypothesis is this, is that the majority of ACE inhibitors are eliminated by the kidney. And as the kidney function falls, perhaps there's an accumulation effect, and the effect on potassium is increased. ARBs have a mixed elimination pathway and probably have a reduced risk of hyperkalemia because of that. Again, is it proven? No, but that's my thought. And again, just to prove the point, another study by Chang and colleagues shows that as kidney function falls, the proportion of patients with hyperkalemia increases. And as appropriate, if you're hyperkalemic, you probably have more reason to have an increased frequency of labs being drawn. So let's talk about a case. All right, here's a 53-year-old man with chronic kidney disease. He has stage 3B. That means his GFR is between 30 and 45, and his is 34. He has type 2 diabetes. He has hypertension, dyslipidemia, and proteinuria. His current medications include lisinopril, hydrochlorothiazide, atorvastatin, aspirin, metformin, and linagliptin. And we have a laboratory test that shows hyperkalemia with a serum potassium of 5.5, which was repeated and showed a similar result. You got it? All right. What do? Do you reduce the dose of lisinopril? Do you discontinue lisinopril? Do you increase the dose of hydrochlorothiazide? Do you add furosemide 40? Or do you add sodium polystyrene sulfonate, KXlate? All right, so pick one of those answers for me. Well, thank you very much for the diverse opinions. That's phenomenal. So the good news is, if it cooperates with me, here we go. This is not. Here we go. Is that you're no different than anyone else. So this is the Chang publication, all right? And so here we have actions taken after hyperkalemia. And you can see I didn't give you all the choices. And I cheated a little bit. I'm going to tell you why I cheated a little bit. But regardless, I did tell you we repeated it. So that was a major effect, right? But the percentage of choices, you can see where you might fit and what percentage of the rest of this population in this study did. But again, a diverse opinion, which is consistent with other research. So again, I thank you because, again, it proves my point. And that depending on who you are in your practice setting, what you might do, you choose a different option. Now, each one of those, there's a problem. Each one of those is a significant effect for the patient, whether a decreased dose of a drug that's helping them, or stopping a drug that's helping them, or adding another drug which may cause other adverse effects, so on and so forth. So I'm setting you up, I think, is what I'm doing. All right, but before I do that, I want to have you answer my questions about kidney excretion. So that becomes important to some extent. So does the proximal convoluted tubule secrete potassium? Is it the loop of Henle? Is it the distal convoluted tubule? Or is it the cortical collecting duct? So answer that question for me. Fantastic. So whoever chose 4 was correct. So the good news is I have an opportunity to actually teach you something today. Well, that's great. Thank you. That's fantastic. I'll feel accomplished today. All right, so what is normal? So one of the things I teach my students is you can't understand abnormal unless you understand normal, right? You don't know those things. So again, what is normal? Well, we know that potassium is intracellular. In fact, the extracellular potassium that we're talking about, serum potassium, is really such a small fraction of the total potassium load. And in fact, muscle cells, liver cells, red blood cells all have the majority of potassium stored within them. And the very small percentage, and this is even to scale, of the extracellular fluid has potassium. But everything is in balance. So we take in 100 milliequivalents, 100 milliequivalents leaves. It's when those things are broken when disease happens, when hypo or hyperkalemia occurs. And the majority of potassium is excreted by the kidney. So you can imagine if the kidney's not working, and again, that's my world, you're going to see hyperkalemia. In this graph, and it's a little bit harder to see, but these first 3 segments of the nephron, the proximal convoluted tubule, the loop of Henle, the distal convoluted tubule, all are responsible for reabsorption primarily of potassium. It doesn't occur until the late segments of the distal convoluted tubule that some chemical changes are occurring, and then secretion occurs in the cortical collecting duct. So let me show you that a little bit more in a moment. And again, to reiterate the point, what else is going on? What are the factors determining the secretion or reabsorption of potassium? Well, in this regard, here was I did draw that kidney. It's not pretty, but it may be a little hydronephrosis here. But you have decreased renal blood flow, which releases renin, which converts angiotensinogen to angiotensinogen 1, which is converted to angiotensin 2 by angiotensin-converting enzyme, which subsequently will trigger the release of aldosterone, which increases the blood pressure to fix the initial insult, and resulting also in hypokalemia. All right, so alterations in this, and we have drugs that interfere with each one of these stages, and that can influence the potassium level. So this is the distal convoluted tubule heading into the tubule lumen of the cortical collecting duct. So what happens here is the sodium delivery to the distal tubule prompts a change in the chemical gradient in this area. And as a result of sodium being delivered to this area and reabsorbed into the principal cells through the epithelial sodium channels, creates a negative charge on the tubule lumen. In order to make sure that it remains neutral, potassium is pumped into the tubule lumen to make sure that there's a neutral charge across that membrane. And so again, this is essentially why we are secreting potassium. It's sodium delivery to the distal tubule. So in fact, what's interesting is that a low sodium diet will actually make it more difficult for you to get rid of potassium, because you have decreased sodium delivery to the distal tubule. It's also the reason why you see drugs like loop diuretics, for example, which are increasing the amount of sodium in the distal tubule will have a pronounced effect on potassium levels. Okay, now the body, we have an incredible ability to control that. We can titrate, just like in a chemistry lab, we can titrate that pretty nicely. We can reduce the potassium excretion down to about 10 milliequivalents a day. So in starvation, we can actually control the elimination of potassium. And if we have an excess in healthy kidneys, we can increase our secretion up to about 400 milliequivalents a day. And what it does is that the release of aldosterone increases the number and the activity of all these principal proteins, which is, I think, a phenomenal effect of what our kidneys can do. Everyone thinks about they filter and what have you, but these are sorts of things that get, I think, me excited. So, okay, this is a statement that my nephrologist I used to work with when I was much younger used to say, hyperkalemia waits for no one. And it means that because the extracellular fluid is so sensitive, changes, redistribution, and changes in intake and secretion, potassium levels can change very quickly on you. In fact, in a crush injury, when you release that crush, the potassium from the muscle cells can actually flood the extracellular fluid and cause hyperkalemic death. So again, hyperkalemia waits for no one really means to me that you can measure the potassium today, and tomorrow it will change dramatically for you. And it has significant adverse effects, clearly, obviously, the most substantial of which is the changes to the heart rhythm. So how do we manage it? Like I said before, we don't have good options. So here's a question. Which of the following serious adverse effects related to sodium polystyrene sulfonate, or caxylate, resulted in an FDA safety labeling change? Was it exacerbation of heart failure? Was it elevation of blood pressure? Was it development of colonic necrosis? Or was it the risk of acute kidney injury? Go ahead and answer that question. Okay, so the right answer is 3 here. So a good portion of people got that correct. It is the development of colonic necrosis. So here are our current therapies for hyperkalemia. We have caxylate, which I just mentioned. I'm going to talk about caxylate because it's something that we're very familiar with to some extent. And the new one, which is Patiromer, which is organic polymer resin Patiromer calcium sorbatex, which I'm just going to say Patiromer if you don't mind. So this is sodium polystyrene sulfonate, or caxylate. I'm not sure the last time you looked at a package insert for this drug, but it's worth taking a look. There's a ton of contraindications. We can give it orally. We can give it rectally. It's available as a powder, as a suspension, as an enema. The typical dose is anywhere from 15 to 60 grams in a day. And you administer it 1 to 4 times a day. And the cost for, if you gave 1 15-gram dose a day daily, the cost of that will be about $762. This is a drug that's been around since the 50s, 60s, right? And still a substantial cost. And I want you to remember the 1 to 4 times a day because that's also important. What are the issues? Well, there are no rigorous clinical trials to determine efficacy and safety. Not a one. Not one. It takes hours for it to work. So the best order I've ever seen is a caxylate order stat. Because I know it's not going to work in an hour. It's going to take like 24 to 48 hours. So in emergent hyperkalemia, really probably not useful. Questionable efficacy when not combined with sorbitol. I'll tell you why that is. And then some safety concerns, and lastly, some drug interaction concerns. So the original study was a case series of 32 patients. Those patients were end-stage kidney disease patients. Hemodialysis was not yet available. It was available in probably a few centers as an experimental treatment back in the early 60s. So they came up with this drug, and it decreased it by about 0.9 in 24 hours. Some retrospective analyses confirm that it worked. But back then, it was most often combined with sorbitol, because when they first released a drug, it was a powder, and they mixed it with water, and they had significant GI effects. They had bowel impaction, significant constipation, so they very quickly turned it around and mixed it with 70% sorbitol, which recently was decreased to 33% sorbitol because of concerns that sorbitol might have. So I went searching to find a trial that more contemporary design might apply and see if the drug would stand up to modern day medicine. And lo and behold, I was happy to find a study, Safety of Efficacy in Caxlate in Hyperkalemia. And I was thrilled, but then quickly realized that this study was prematurely terminated for safety reasons due to the high frequency of adverse effects in the Caxlate group. But we still use it. So in a very controlled environment, very picky in terms of what patients get into a clinical trial, monitored very closely, couldn't get the study to finish. But yet we're using it every day in clinical practice. The colonic necrosis, here's the story. Not a lot of good data, and it's hard to study. It's hard to get a lot of volunteers for this type of thing. Some retrospective analyses essentially show that probably 0.3, 0.4% incidence. Doesn't sound like a lot, but if used in a lot of people, you're going to see it. And that's a bad outcome. So again, that led to a safety change by the FDA. Drug interactions, the FDA put out this safety communication. You may have seen this, you may not have, a couple years ago. And it said, prescribers and patients should consider separating Caxlate dosing from other medications by at least 6 hours. Okay. Think about how many medications somebody might be on and how you time that. And that's if it's once a day. If it's 4 times a day, good luck. Of studies, not good studies out there, but essentially shows reduction in absorption of a couple of drugs. So not good data on it, but that's the FDA's recommendation. All right, so let's talk about some of the new drugs that might be coming out or are already available. Patients prescribed Patiromer. How long can the product be left out of a refrigerated environment? What's your response? 1 week, 1 month, 3 weeks, or 3 months? Okay, so the correct answer is 4. 3 months. All right. Some good information for you. All right. So here is Patiromer. It is another potassium exchange resin, but Caxlate exchanges potassium for sodium. So there are some concerns when you exchange potassium for sodium. When you get sodium absorption, you're trying to treat hypertension, you're trying to treat heart failure, you have edema concerns. So there is that concern. This exchanges potassium for calcium. All right? Its primary effect is the colon. It's not absorbed. There's very specific instructions on how to prepare the dose, so I'll talk about in a little bit. It has to be refrigerated. It's stable for 3 months at room temperature. You have to take it with food. It's once a day. The starting dose is 8.4 grams a day, and you titrate it weekly to one of the next doses if you need to. And the cost for a month's supply is a bit less than $600. So those concerned about cost, from a chronic management point of view, already we're winning. Now, the drug interaction was a concern. When the drug first got released, it had a boxed warning for drug interactions, and you had to separate the drug 6 hours in either end to any drug, similar to the way Caxlate is. But that came from a series of in vitro studies of about 28 drugs, half of which were bound. The other half were not bound. But it was an in vitro study, not in vivo. So there were concerns about how much you can relate that to patients. So that was followed up by some in vivo studies, and they looked at these drugs here, and they found low risk of drug interactions with other drugs. The only two that came up significant on this list was ciprofloxacin and levothyroxine, which are drugs we are very familiar with having interactions with other things. And we already separate those drugs out. And so the box warning was dropped, and now it says to administer other drugs 3 hours before, 3 hours after, which I still don't necessarily understand because it's been proven that they don't interact with a lot of things. But it's a little bit more palatable from a drug administration point of view. There were a series of 3 major trials that got this on the market, and I superimposed these jewels just to help my mind work. So the Amethyst trial, and again, if you don't know what an amethyst looks like, well, there you go. This was patients with kidney disease and diabetes. This was patients that were hyperkalemic. They were on RAS inhibitors, so ACE inhibitors, ARBs, things like that. It was a year-long study. Pretty good as far as clinical trials are concerned. And basically, it worked. The majority of them were still on the drugs that were important for their condition. The OPAL study was in patients with hyperkalemia. They were CKD stages 3 and 4, so a higher risk population. It was a little bit shorter duration. This was 2 phases, 4 weeks and 8 weeks long. And again, effective for the effective agent in that condition. And then the final trial was the PEARL study, and this is in patients with heart failure. And what they showed, these patients had an indication for spironolactone but couldn't take it because of hyperkalemia or had a previous insult from hyperkalemia. So as a result, these patients were able to go on spironolactone, get the therapy that's important, that reduces morbidity and mortality, and not get hyperkalemic. So let's look at some of the data. And it's exciting, but the same story throughout. So this is the Amethyst trial, beginning days all the way out to 52 weeks, and then after they stop the drug. All right? So again, x-axis is serum potassium, y-axis is weeks. Potassiums, regardless of mild or moderate, drop and stay within range and then go up after the drug stops. The drug works. Here's OPAL. Again, second trial I said, mild, moderate hyperkalemia, potassiums go down and stay within range. Again, the drug works. PEARL, this is the heart failure trial. This was, again, placebo. You see potassiums go up from baseline and go down despite the addition of spironolactone, and a dose increased to 50 milligrams halfway through. One more benefit, potentially, this is early. Okay, this is not an approved indication, but this was a follow-up study that was done. And it shows basically a change in serum aldosterone levels in patients with mild and moderate hyperkalemia and a secondary finding of a reduction in blood pressure that was independent. Again, reduction in blood pressure. So that's a pretty important finding. So maybe we have a way to also have another benefit. Again, early on, just some preliminary data. It's only 4 weeks long, but some exciting results as an additional benefit. All right, so prescriber calls to ask about Patiromer dosing and titration. What is the starting dose? Is it 8.4 grams once a day, 8.4 twice a day, 16.8 grams once a day, or 16.8 grams twice a day? We'll test your recall knowledge here. All right, good. So the answer is 1. So for those who are paying attention, you got the right answer. Good for you. Now I know what percentage is not paying attention. Okay. Okay. So what's the next therapy? What's emerging? Well, this is the next agent that we may see. There are a couple problems that we're running into with this one, but we'll talk about those. So this is DS9, all right, and this one is is again, another potassium exchange resin, exchanges it for hydrogen ions and sodium ions. So again, another exchange resin, a little bit different from Caxlate, obviously different from Patiromer. It's not been a smooth road for this particular agent. The PDUFA date was last year in May, and they got a complete response letter from the FDA, and there were nothing wrong with the drug necessarily. It works, but there's something going on with the manufacturing plant. So they would not allow the drug to get approved. So they did whatever they had to do, and they resubmitted in October of last year. And just on St. Patrick's Day, got another complete response letter, same thing, something on with the manufacturing plant. So again, the drug is not approved. If they figure out what's going on with their manufacturing process, it probably will get approved. But again, just forewarning you, what I'm about to tell you is based on some of the trial data that's out there, but not an approved agent. So again, this is another exchange resin. It's not absorbed. Traps potassium throughout the intestine, and again, exchanges it for sodium and hydrogen ions. It's available as a powder, and here's one perhaps benefit that I think that may win out on Patiromer if it comes to market, and that is it's going to be a dissolvable tablet. So I think that's a benefit for some. I think some people have a thing with liquid. Maybe they don't want to mix the thing in the liquid, the powder, but that might be a win. First trial I want to kind of go through was the HARMONIZE trial. This was a phase 3 double-blind placebo-controlled trial. They had a 48-hour open-label phase, and then those that got to normal kalemia, that they got to normal potassium level, they got randomized to one of 3 doses, and then they watched them for 4 weeks. They had 258 patients that were in the 48-hour phase, and the majority of them went on to the 4-week study. And the drug works. Okay, so this is the different doses they gave over the first 24 to 48 hours. What's remarkable about this is that it works very quickly. In fact, we're talking, this is the first dose, and within the first couple of hours, potassium levels were going down. So I think that if this drug does get to market, you might find a new agent that actually you could use in emergent hyperkalemia. So in the hospital setting, this might be a win. And actually, if you think about the other agents we use for acute hyperkalemia, the acute management, none of those drugs are necessarily effective for getting rid of potassium. So they just hide it somewhere else. Or you protect the heart from the hyperkalemia. You can use diuretics, but that always isn't effective, and hopefully your kidneys work and that works. The only other option you have is dialysis. And it's not like you can call up someone and say, we need dialysis, and it happens in 30 minutes. It takes some time. You need a catheter, and it's a process. I've been there. So again, it's not easy. And so this might be a win, at least as far as I'm concerned. Okay, and it didn't matter who you were. All patients, history of kidney disease, heart failure, diabetes, taking a RAS inhibitor, what your baseline potassium level was. Didn't matter, potassium levels went down, the drug works. As far as adverse effects are concerned, this is, again, pretty clean. Not a lot of GI effects. You can see that there's a dose-dependent effect on potassium levels, so you've got to be careful about titrating this. The more you give, the more likely you're going to end up with hypokalemia, and we don't want that either. But the one that has me a little bit sort of worried is this edema. So it seems to be a dose-dependent effect causing edema. And when you throw sodium in a product, I don't know. So again, something to keep an eye on, at least if the drug gets to market. Now the other thing, if you look at the PACM trial, they did not have any edema in that trial. Primarily GI in nature, pretty well tolerated in the study. This was another phase 3 trial, patients with CKD, potassium levels between 5 and 6.5. It was a dose-ranging study. They did not really get to the other dosages, so a little bit lower. And the majority of them got to a normal serum potassium. And similarly to the other study, the steepest decline was in the first 2 days. And again, didn't matter. As you can see, those 3 lines indicate a dose response. Okay? The higher the dose, the lower the potassium went down. Now, how do we integrate these? So I'm coming up towards the end here. Patiromer requires some effort to get it covered by insurers. That's certainly a barrier for us. We're making some phone calls. We're writing letters. It's a little bit of a challenge, but we've been fairly successful. The availability right now is limited to specialty pharmacies and select community pharmacies. Now, I work on the side in a community pharmacy once Sunday a month, and I checked to see if I could order it. I can't, because it's linked to certain community pharmacies that are in certain networks. And so, again, it's not everywhere, but it is out there. There's some storage concerns for some pharmacies. If you have it in stock, it's a box, and if you have the right size fridge, and there's some issues there. Use in hospitals, well, some of you work in hospitals. There's always budgetary concerns, formulary concerns. There's always a new agent coming out. You have to kind of weigh this and see if it works in the system or not. Personally, if you have Kexley, I think this is a better drug, Patiromer. I got to be honest with you. I just think it's better. So I think it's going to win. It does require some specific storage and mixing administration considerations. If you ever go to the package information, you'll see that they have to pour a certain amount of water in. They have to add the powder, then add more water, then stir, then drink. And there might be more granules, and you have to pour more water in and drink more water. So it's a little bit cumbersome. You have to counsel the patients effectively, because if they don't do it right, they're not going to get the benefit. And if it's a big clump in the middle of the thing, they're not going to take it. So you got to make sure you counsel those patients, because otherwise they're going to waste the dose. I think there's multiple opportunities for us here. I think, first of all, if anyone works in any setting, whether it's hospital, community, and someone gets Kexley, you're not going to get a best friend there in the patient, because they're typically going to have a bad outcome. They're not going to be happy with you. We had a patient years ago. We have a thing in Albany called Live at 5 in the summer. They go down to the river, and there's a concert, and they go and hang out. And patient was hyperkalemic on a Friday. Nephrologist calls her up. I need you to go to the pharmacy and pick up this product. Your potassium's high. She takes it, picks it up, and goes to Live at 5, takes the dose. She didn't see the concert. She was in the porta potty the whole time. So again, has a significant effect on patient tolerance. I think you certainly have an opportunity to counsel patients, identify patients at risks, make sure patients are motivated to understand their risk for hyperkalemia and seek care when there's a problem. And the final thing is, I think dietitians should become better friends to us. I think they have a huge impact on potassium intake, and I think potassium is not often thought of in terms of what they're taking in, particularly if they're hypertensive and they're on a DASH diet. And guess what? They take a salt substitute, which is a potassium salt, which increases their potassium load. Lessons learned. Well, I am not a fan of Kexley. I think I probably said that enough. I think it's limited. I think its day is past. I think we're in a new era. I think Patiromer and perhaps the S9 and perhaps other agents down the road will win. Patiromer is certainly effective. Its use in emergency management is not approved, but it may be used. Who knows? Adverse effects are known and seem minimal, primarily GI. It does affect magnesium levels, so you got to watch that as well. But no serious problems and low risk of drug interactions. ZS9, well, it's not approved. No long-term studies, no 52-week study yet, so we can't really fully evaluate long-term use. But it certainly appears effective for acute management of hyperkalemia. Conclusions, this is a common complication in patients with multiple disease states that we all see. Certain medications cause the increased risk. Again, SPS has questionable efficacy and safety. And I think the new agents certainly have a role for us in this area. Good. Thank you guys very much for your attention.